to you, Professor, once again, Professor Ojo, to take us through Module 2 of physical examination and diagnosis of the shoulder complex dysfunction. We were privileged to have him last 2 weeks to discuss with us the Module 1 of physical examination and diagnosis of the shoulder complex dysfunction. I would implore all of us joining to, as much as possible, to mute our microphones, and those of us that want to show our video, put our videos on, make sure that the background is quite decent, such that if it goes out, it wouldn't bring any ethical issues for us. So if our prof is ready, I will hand him over to commence today's session. Thank you.
Good afternoon, my people on this platform. I want to really appreciate my friend from Ghana, Adu, and I want to appreciate Ibrahim as well for bringing me on board, especially for this webinar. It's been a good thing for us to share knowledge, especially among ourselves when it comes to physiotherapy profession. I want to appreciate people who have joined in my country here, and who are still going to join, at least in the meeting. Again, I appreciate you all. Right, I think you can start in earnest. Right, good afternoon, everyone. I want to share my slide with us now, so I'll be able to move on and be able to see how you can go with it. Thank you. Yeah. 1 minute. I think everybody can see my slides. So last week we discussed majorly on the anatomy and pathophysiology of shoulder complex. Today we are going straight into the physical examination and diagnosis of the shoulder complex. And again, I want to appreciate my people all over the world, especially from Ghana, that are shouldering this webinar. Thank you very much. When we talk about when we talk about examination, examination is very much important in the management of any joint, because there you are able to reach the diagnosis. If a correct diagnosis is not made, there cannot be a good treatment approach or a right treatment approach. You waste your time, you waste your effort, and patient too will waste his money and his effort. So in that's why there is need for us to have appropriate diagnosis. And you cannot do that if you don't have the real examination that we're supposed to have. Then, because of that, we have to go through this. The mindset for this workshop is that wherever you are, you're able to practice what I'm going to be demonstrating here for us today. Okay, you don't have a friend with you, you are alone. You can easily touch your shoulder and possibly make the movement, so that whenever you now come about any patient or thereabouts, you'll be able to know what to do. In a normal sense of it, in a physical class, we put ourselves into groups, and patient or you or somebody will pick someone to demonstrate what we are talking here, there, exactly. And that gives you an idea of what you are talking about. And one can go there, practicing it with patients. Yes. The shoulder examination begins with history, not with inspection alone. Begin with history, right? After then, you have to inspect the joint. You have to palpate it, right? To palpate the anatomical landmark. Then you assess the joint, especially the movement. Then you now compare that movement or your palpation to the other side to be able to ascertain if there's a problem there or not. All of us are physiotherapists and we train in universities. We know the sub-format, right? The subjective, objective, assessment, examination, planning of your treatment. Then you set your goal and you go with your treatment. We are going to take all this one by one regarding the shoulder joint complex. All right. The subjective aspect of it is important. That may take us directly to where the diagnosis is. Even you can have the diagnosis right from the time that you are taking the history of the patient. That is why you cannot decision the history take. You have to take some information, age of the patient. Many problems can be age-related. Talking about rotator cuff degeneration, this may occur at the age of 40 to 60 years. Right. So whenever somebody is complaining of pain at the shoulder, and there was no history of fall, no history of maybe accident or what, can be two things. Maybe rotator cuff degeneration, maybe osteoarthritis. Right. That's age-related. If somebody is between age 20 to 40 years, you may be talking of calcium deposit, right, in the joint. Somebody that is less than 30 years, we may be talking of collagen chondrosarcoma. And when you talk about this, you are talking of, you know what you are talking about. That may be possibly somebody is talking about maybe cancer of the bones or cancer of somewhere else that is getting a pain into the joint. Issue of fall or trauma may indicate maybe fracture, right? Fracture or injury to the muscles. So those issues are extremely important when you are talking about patient examination. Then I put something here for our understanding. If the patient fall on outstretched arm, somebody is falling from a tall and he push his hand forward. In that way, if he lands on that, then there may be something. There may be fracture of glenohumeral joint, there may be fracture of the clavicle, there may be fracture of acromion or acromial process. All those ones were things that may associate with falling. You call it FOOSA, falling on outset arm. Any movement that causes pain, right, or problem, you tell the patient to do some movement. You understand? And when there is a problem like that, which one exactly? That will be noted that cervical movement can cause shoulder pain. There can be radiating pain from the cervical region that goes into the shoulder, radiculopathy. So most of the time, you examine the neck as well. Whenever you examine the shoulder complex, so it's going to give you the balance. Either you have pain at the shoulder or you have pain at the neck. You'll be able to know, right? Very important for the shoulder joint. Patient with recurrent dislocation may have been involved in any movement which may regard the lateral rotation. What we are saying is that if there's lateral rotation of the shoulder joint, right, and patient has sustained dislocation of the shoulder joint before, that movement will be fearful. Patient will be fearing that movement. Patient will not want to do it. So you know that possibly this patient has had this one before, then one is careful with it. Night pain and resting pain are related to rotator cuff muscle. Occasionally, it may be tumor, at least of the joint. So How long has the problem been affecting the patient? It's a thing that we have to possibly consider as well. All right. Idiopathic frozen shoulder may go through 3 stages. The condition may become progressive, right? It may be worse at the initial stage. After a while, it becomes plateau, that the symptoms seem as if there's no symptoms again, or possibly the symptoms is not moving, it's not progressive. Then, after then, there can be improvement, even without any medication. Call it idiopathic frozen shoulder, because you know there's a mechanism in the body that gives the healing, natural healing in the body. So in that wise, patient may have some improvement. And that's why we will take that it may be that somebody is having idiopathic frozen shoulder. Any activity that causes the pain, you may have to ask that. Any heaviness, any weakness in the limb, because the limb gets tired easily. So this heaviness in the limb is pointing towards possibly there's a kind of venous problem. Vein does not return very well, or there's circulatory problem. There can be problem with the lymph vessels and some other things. Then there can be swelling, there can be stiffness, then it can extend all the way to the finger. Any numbness, any wastage, all those ones are what we have to know. Am I having any problem with my communication? Are people hearing me?
Prof, you're loud and clear.
Yes,
Okay,
we are.
Thank you very much. Thank you very much.
Yeah, yes, we are.
Yes, God bless you. Any numbness, any wasting. So all those ones are what we have to take care of, or to know. I know when you talk about paresthesia, you are talking about this, but maybe dorsal nerve root impairment or affectation. So still we are still on the history taking, right? And after the history taking, there may be more to that. This is just about 1 hour or thereabout webinar. There may be more to that. But if you are able to go with what is on the ground, you'll be able to get some information. The observation is extremely important. In this case now, you use your eyes to look at what you have there. And that's why your patient should undress, remove some part of the clothes, either male or female, that doesn't matter now. Your interest is on the shoulder joint, and you try to look at it very well. It's important that the patient is observed, right, as he or she removes and replaces the clothes. The problem there, or the point there is that, right, even if you are not very close to the patient, then you try to see how he does it. Right, how he's removing it. You see the kind of movement that patient is trying to prevent. So that may give you an idea of possibly what's happening. E.g., is the affected arm undressed first or last? The patient action is an indication of functional restriction from pain or weakness. So if the pain is mild, patient is not bother himself, he may remove that affected arm first. But if the pain is worse, then it may be difficult for him to do it first. Then if the muscle is weak, then that's another story. You see the patient is struggling to remove the shirt, is struggling to remove everything that he was supposed to remove. All right, very important at least for the examination. Yeah, I think you can see this. We are talking of observation, and this is extremely important. If you look at this 3 pictures you are seeing there, right? This is the anterior part of the shoulder. Can somebody see this?
Yes,
can
Prof.
you see my concept?
Yes.
Yeah.
Prof, we can see it.
Circus. This is common when you have especially patient, hemiplegic patient, that the shoulder has a bit subluxated inferiorly. Okay, we are not dealing with hemiplegic patient now. If somebody has inferior dislocation, you will observe this. You see that there is a kind of gap between the head of humerus and the acromion, clavicular acromial joint. Can see that, can see. But as we are going down, we are going to discuss more on this because we have the sulcus test that we do. Right. There can be posterior dislocation. This is what you have here. This is a typical example, right? The osteology of it. You are not going to be able to see this, but you can see this. You can see this, right? You can see that this is right. The descending of the what do you call it, of the head of the humerus here is more to the back than to the side. Because the anterior one, this is going to be swell. This side is going to swell up. Going to swell up, right? Onto like what we are seeing here. It's going to swell up. So we call it. You look at it. This posterior dislocation. That this is sulcus. This sulcus aspect can have you can have anterior dislocation with this. You can have inferior dislocation with this. Right? When you look at it anteriorly and you are seeing the bulging at the anterior side, that's anterior dislocation. Right? But if you are not seeing the bulging of the anterior side, right, the two sides are normal, but you are only seeing the sulcus is what's called inferior dislocation with your observation. Right? You have made the diagnosis and now know what to do with the patient. All right. Yes, I put here some observation at the anterior part can include sulcus sign, if you have seen. There can be deltoid ectroby. There can be dislocation of the clavicle at the acromioclavicular joint. Right? I think I have some picture here for us here to be able to see. Yes. Are you following me?
Yes, Prof.
Yes, yes, sir.
Yes, we are.
You look at this
Yes,
very
sir.
well. You look at this very well. Look at this very well. Look at this old man. Look at the anterior, look at the shoulder here. Look at the shoulder here. You discover that the deltoid here has flattened off. Has flattened off. Right. But you do not see the sulcus side. Look at this one. There was no sulcus here. They only seen the atrophy of the deltoid. I think you are following me. That this is well shown here. There's no separation between the acromioclavicular joint and the what do you call it, and the head of the humerus, as we are seeing in the other joint here, as we are seeing here. I think you are following. Yes. So then, when you look at this, right, we have we call it shoulder separation here. Shoulder separation. Because here, the acromion is distinct. Then you compare this to the other side. Other side. Can you see this? Can you see that the acromial process here is not as distinct as what you have here? Look at the edge here. Look at the edge of the acromion process here. Yes, and look at what you have here. So this is not sulcus side. This is the kind of dislocation of the clavicle, right? Possibly from the acromial process. You can see it's so big here. There's very much minute here. So all those ones were part of observations that one needs to make. And once you can get here and you observe this, then you record it and you know what next we are going to do. We have more to that. And you can see this as well. I've shown us this last week. This scapular dyskinesia, that this is more or less like a wing scapula. That this is when the inferior edge, inferior border of scapula is protrude. Yes. This is when the lateral border or the medial border, medial border is protrude as well. Right. This is when the upper border of the scapula is protrude. For all those ones were scapular dyskinesia that you just have to pull down. Right. You know, all this one, they capture wing scapula. And when you talk about wing scapula, it can mean various categories. So one should know that you understand it. Right. This is the posterior observation. You know, we are talking about observation. This is the posterior view of the patient that you have to document, talking of diagnosis. We have more to that, right? Yeah, please look at this. Can you see this? Look at this. You see that all the scapular hair, they look as if they were coming out. Unlike this, what we are trying to repeat here. But to act here is what we are seeing here. Right. This is a sign that you have problem with long thoracic nerve palsy. Long thoracic nerve palsy. So in this wife, the serratus anterior, right, and subscapularis are very much affected, and the shoulder is not coming out, and the scapula is not coming out. But when somebody is standing normally, it can bulge out. It can bulge out. All right, I call it long thoracic. Now, I still going to get there as we are going. Yes, we showed this one again yesterday, last week. All right, right? I think, can somebody tell me what we have here regarding what we showed the other time, last week? Who can tell me the problem we have here? No idea? Okay, here we are having palsy of the trapezius. This area, the lateral aspect of the trapezius is, there is weakness there. There's weakness there. And that's why it cannot lift up the spine of the scapula to the appropriate position. So therefore, the shoulder or the scapula is going down. And patient will not be able to do shrugging of the shoulder. It's not going to be able to do, it's not going to be able to lift the shoulder up. Because what I'm trying to do is by effect of the trapezius muscle. So that trapezius palsy here. You understand? So patients having a problem of trapezius weakness, and that patient is not able to do it. So when you're able to record all this, I think you're about 20 to 30% into the solution or into the problem that patient has. So what you have to do is that you just have to provide what the solution is, at least for the patient. Right. Yes, you can see this again. This another combined. In this case now, look at this one is very, very much prominent. This one is having long thoracic problem and is having dyskinesia as well. So in that wise, that's a problem, right? This one, this is what you're having here as well. All right, so we call it combined loss of function. Combined loss of function means scapular, right, in addition to some other dysfunction. So all those ones are what you have to document and try to see what you can do. I think that's another one here. Yes. Yes, when we get there, we are going to still see more. All right, come 1 minute. Yes. Then we come to the palpation. You have seen it, but there are some things that you may not be able to observe physically if you are doing the examination. All those ones are what you can see, but there are some that you may not be able to see. If you are not able to see it, then you go to palpation. All right. It's a physical examination that technique that involves feeling the shoulder muscles and the bone. You palpate for tendinitis, you palpate for swelling, you palpate for other abnormalities like bursitis, tendinitis, tears, sprain, and strain. The palpation is important in order for you to be able to know, right, where the problem is. Where the problem is. Some people may misdiagnose bursitis. Some may misdiagnose tendinitis. And they will say that exposure shoulder. Like somebody may have tendinitis of the long head of biceps, right? So in that case, right, just touching that long head of bicep initiates pain. And if you don't touch it, you'll be thinking there's a problem somewhere, because patient problem will never be resolved until possibly you touch it. So in that way, palpation is extremely important. When you palpate as well, you're assessing for the temperature in front of the shoulder, palpate bony landmark for tenderness, which I've mentioned. Then you have to palpate some of the small joints that are associated with the shoulder joint. Sternoclavicular joint, the clavicle, acromioclavicular joint, acromial process. Then you have to palpate the scapula as well. Then there's a border, the border of scapula has to be palpated, because in that place, there may be some pain, maybe inflammation of the muscles around that area. that may lead into pain at the posterior region, and patient will complain. So once you're able to touch it and there's pain there, you know that, okay, this is a problem, maybe inflammation of some muscle there. Or there can be fasciitis, inflammation of the fascia that's under the scapula. You can touch it. All right. So when you palpate the bursa as well and there's pain, then you know that this is bursitis. Palpate the glenohumeral joint line, anterior and posterior. Yes. Palpate the muscle bulk of the supraspinatus, infraspinatus, and deltoid muscle. You have to palpate them. Especially of the long head of bicep, you have to touch it. So if any of those ones indicate pain and not swelling, it may talk of tendinitis. And when you know tendinitis, you know what to do exactly. Yes, I try to put this one here, right? When you touch this place, in terms of your palpation, patient will feel pain. And that's why you put it in red and color. Touch it, patient will feel pain. If you touch it there as well, patient will feel pain. If you palpate the muscle, there may not be pain. But touching that will feel pain. In this case, when you touch the deltoid muscle, there may not be pain. There may not be pain. Right. So you may have to shake to move the acromioclavicular joint. You have to move sternoclavicular joint. You have to move them, touch them. Do you understand? Palpate the trapezius, go to the back and palpate the scapula to be able to ascertain if there's any tenderness regarding the joint. All right. Yes. I try to put picture of the bursas here. The thing is that if you are unable, if you forget to palpate those bursas, right, you'll be thinking or you'll be misdiagnosing the patient's condition. Because if you had inflammation of the bursa, right, which on the touch is painful and didn't touch it, you'll be thinking that it may be muscle, it may be oil of the shoulder, it may be many things. But just that inflammation, I know the bursitis is what we are after. So you just have to palpate it, feel it, and get the problem and be able to know how to resolve it. Right. Yes, I've mentioned this. Palpate all the joints around the shoulder to have the feelings of the dysfunction, if any. The small joint can be passively moved to test the pain and instability. Yes. Sternoclavicular, acromioclavicular, scapulothoracic. You have to move them to know what and what they are there. Then we now come to range of motion after you have been able to touch, right, all those things. You discover that patient is having issues with the range of motion. There is this stiffness, either there is frozen arc or in the extension, in the flexion, the reduction in range of motion. So when there's reduction in range of motion, right, you know what to do. You have to measure the goniometry of the shoulder. Of course, you may not be able to measure goniometry of the acromioclavicular joint or sternoclavicular joint, but when somebody moves the shoulder joint, you may have to observe the movement there. The movement there. We call them component movements. So if they are painful, then you note it. When somebody is moving the shoulder as well, if the scapulothoracic joint is painful, you note it. What kind of candidate may not have pain at the glenohumeral joint? The email is going to have the pain at the scapulothoracic joint. So that's why you know where you are going. But if the patient is having problem at the glenohumeral joint, then your goniometry is very important. And I try to put how to measure goniometry here. Oh, I think I put it here. Okay. I try to start with this. Apis crash test. Apis crash test, right, tells the flexibility of the shoulder, which assess the range of motion. And what do you tell the patient to do? Just tell him to possibly touch his back. Take the hand right up and touch the back. Just touch the back. So when you touch the back, then if the patient is unable to be able to do it, that's why there's a limitation in range of motion. He does that from the front, he does that from the back. Do you understand? The two, right? You discover that patient is complaining of pain, then there may be a problem. Can even tell the patient to do the two, using one hand to touch the other hand at the back. Maybe the left is put at the back. Now tell him to use the right to touch it. To touch it. If you are unable to touch your hand at the back, that's limitation. And when you have the limitation in such a way, you try to go on for goniometry. I try to give the such explanation at least here. We call it aptly scratch test. Tell a patient to just scratch the back. It goes a long way in assessing what the patient is having, at least regarding the joint. Right. Then again, if you are trying to document objectively, say for instance, you are measuring, you are talking of the right joint, right? You tell the patient to put the left joint there, and you now tell him to touch his hand using the right hand. If that right hand does not touch the left, you can measure the distance at the back. So when you measure the distance at the back, as you are managing the patient, do you understand? You try to now assess again how far you have gone regarding that. So the measurement may be 1, 2, or 3 centimeters for the fingers, especially the middle finger, to touch each other. Right? Then after the treatment, you measure it again. Right? You now discover that either that measurement is reducing or increasing. Right? You can tell them to clench the fist and touch it like that. So you'll be able to do your measurements. One of the outcome measures that you can use, at least in assessing the progress of our intervention. Test assesses internal rotation, adduction, abduction, external rotation. It also checks the numeral joint stability and looks for rotation, rotator cuff muscles, what do you call it? Tears. So if there's tearing of rotator cuff muscles, patient will not be able to do that. I think you are following me.
Yes, sir.
Can we go on?
Yes, we are.
I don't think we have problem with goniometry of the shoulder joint. I don't think I have to spend some time here. I don't think so. I don't think so. If we are having issues with this, I think when we read the literature here, I think maybe when you get to the YouTube of my friend Adu, they'll be able to get more of this. You understand? But I try to put the goniometry of the shoulder joint here, the position, recommended position, you understand? Alignment of the goniometer, I put it there, and how to measure, and how to read them, I put it there. Right, flexion, this is flexion, this extension, all right. This is abduction. These are recommended standard position that we can use to do the goniometry, right? This is abduction. Then we have adduction, Then we have internal rotation and external rotation. Patient we have to lie supine, and your goniometry is aligned appropriately like this. Not tell the patient to do, right? The internal rotation, patient can do, you can see now, patient can do internal rotation, then you can still do external rotation. So you measure, right, appropriately, right, using your goniometer. Measure the angle as indicated in the movable arm of the goniometer, right. The external rotation as well can be measured using this. So I don't think I need to move it here to make more ado about this. Right. So these are some of the we call it reference values of the shoulder joints. Right. Flexion can be 0 to 180 degrees, extension can be 0 to 50 degrees, abduction can be 0 to 90 degrees, adduction can be 90 to 0 degrees, lateral rotation. Right. That's how it goes there. All right. Yes. Having measured that, we now need to test the integrity of the muscle. That's where the issue of resisted isometric contraction comes in. We call it resisted isometric contraction. Resisted isometric contraction of the shoulder test assesses the strength of the shoulder muscles and detects possible weakness. Have the patient lie on their back or sit down with their arm resting on a bench. Place the patient elbow to 90 degrees, support the patient arm. Do you understand? Ask the patient to resist your movement. Then ask the patient elbow flex and extension. So in that, yes, this is what I'm trying to say here. So you resist the movement. You resist the movement there. So when you resist the movement there, you are trying to test the integrity of the bicep and possibly long head of the biceps. You are trying to test it. You understand? And if there's a pain, that shows that there's problem possibly with the long head of the bicep itself. You now go ahead and see what you have to do. So resist it with internal rotation and what have you. Then that may show again if there's tendinopathy. All right, tendinopathy. You can have the infraspinatus tested as well. When you tell the patient to abduct, ABD, you can tell him to do the abduction, you can tell him to do the abduction. So all those ones are what we have to do to test the integrity of the muscle. And once you know that any movement there is painful, then you note it. You now try to note the severity of the pain, either mild, either severe. In a case that the pain is too severe and the range of motion is very small, that's so that the injury is very much more. So in that way, you may not be able to do either mobilization technique for the patient because of the activeness of the pain, right? If the pain is mild and you discover that the strength is a bit much, then that may be a kind of grade 1, because there you are trying to test the integrity of the muscle, right? Painful external rotation can indicate tendinopathy in the infra and supraspinatus muscle. So you are trying to test the integrity of the muscle using that. Yes, we come to special tests. Special tests. Now I want us to pay up attention to this. That so all this, we are talking of differential diagnosis. So all these are what we have. We call them variables that we have at the shoulder joint. There can be impingement, there can be anterior instability, there can be posterior instability, there can be inferior instability, there can be labral tears, that may be tearing of the cartilage that is inside the joint. Yes, there can be scapular instability. Muscle and tendon pathology can be there, which we have tested. Then there can be thoracic outlet. We call it thoracic outlet syndrome. All those ones, they have some tests that are peculiar to them. The thinking is that in every dysfunction of the shoulder joint that we have, I think all of them are captured here. Okay, I didn't put osteoarthritis here, but later in the examination, we have osteoarthritis. Somebody says not be signed. Mrs. Abanam?
No, I'm not, Jare. My phone is malfunctioning. Sorry.
Oh, thank you. Thank you. Thank you. I didn't hear me very well there.
I can hear you very well, loud and clear.
Oh, God bless you today. Thank you. Yeah, we are now going to pick each of these one by one and deal with them. Let me say that the examination put here may not be everything. Information is universal now. There may be more to them, but I think that those few ones that are put there, they are easy to practice. If you're able to get them done, then you'll be able to get what you need for the patient, right? If you come across some orthopedic textbook, you'll be able to get more of this, right? But those ones that I put there, they are very common ones that we practice here. Yes. For the impeachment test, we know what we call near impeachment. We call it near impeachment test. Near impeachment test. How do you do that? Okay. The test is designed to reproduce symptoms of rotator cuff impeachment through flexing the shoulder and pressure application. Symptoms should be reproduced if there's problem with the supraspinatus or biceps brachii. We call it NEAR, N-E-E-R. Right? The examiner stabilizes the scapula. This is the hand. You try to hold the scapula with one hand. Then you passively flex the patient's arm. The patient arm can be flexed right from the 90 degree. Now take it off, right? And again, you internally rotate. The test is positive if the patient reports pain. So when the patient reports pain, the test is positive. The point there is that when you do this, the head of humerus, right, as you are looking at it here, right, is brought in contact to the acromion joint, acromioclavicular joint here. And you know, and I showed you that picture the other time, that there can be calcification there. There can be boning spore. So if there's calcification there, then maybe calcification from ligament, the head of humerus will grind it, and patient is going to have pain. If there's boning spore, when you take it to this extent, there's going to be touching of that impeachment bone, and patient will report pain. We call it NIAS test. That's what yes, I've mentioned that. If the test is positive, if the patient reports pain in front of their shoulder, right? A painful act through abduction is often associated with the test. Yes, in this case now, there can be painful act. So whenever patient is doing that and there's pain in the shoulder, go with this test. It's going to make it positive. A significant reduction or ablation of pain after the injection or local anesthetic in the subacromial joint is considered a positive test. Okay, you may not try to do injection, but that is a further examination to confirm what the problem is. Right. Yes, some of us are familiar with this as well. We call it Hawking-Kennedy's test. Hawking-Kennedy's test is another test regarding compared to the NIAS test. The Hawking-Kennedy test is shoulder examination that assesses the integrity of shoulder joint. It's used to diagnose subacromial impeachment or supraspinatus pathology. Here, the patient sits with their arm flexed to 90 degrees and their elbow flexed to 90 degrees as well. Right. The examiner supports the patient arm to ensure relaxation. Yes. So patient just sit down comfortably. The elbow is flexed to 90 degrees, right? And the shoulder to 90 degrees. So what happens is that the examiner holds the patient wrist and elbow and then quickly rotate it internally. Rotate it internally. If you rotate it internally, then there can, once you rotate it, then for it to be positive, there will be pain at the subacromial space. This is where we put the red indication. There will be pain here. There will be pain here. Because when you rotate it, the head of the humerus will turn inside and try to touch if there's any impingement on the arm. Right? Don't forget there's an arc here. So you try to touch if there's any impingement here. Right? And patient will indicate it. And that shows that the Hawking-Kennedy test is positive, indicating impingement of the shoulder. Then how do you manage that? When we get to the management, we discuss it. Let's leave that one until we get to the management. Yes, this is another one, very interesting. I call this one Jochum test. Jochum test. Jochum test or maneuver. Jochum test. Not a common practice, but not to stand is very simple for us. It's used to examine the possibility of a shoulder rotator cuff impingement. Right? Patient can do it. Subacromial impingement syndrome. It's also referred to as Jochum maneuver. How do you do that? Right? I think you are following me. The arm is forced to adduction, ADD, right? And elbow is flexed until the hand is over the contralateral shoulder. Then the patient raises the elbow without moving the shoulder. The test is considered to be positive if the patient has pain during the maneuver. Number one, ask the patient to place the hand of their affected shoulder to the opposite shoulder, right? Just tell the patient, right, to do it to the opposite shoulder. You understand? You now raise it up. Raise it up. So when you raise it up, right, then you can assist the patient to elevate it. To elevate it. If the patient experiences pain or demonstrates signs of apprehension, look at the patient. The face expression is changing. So that shows that the test is positive. It's an impingement test, right, on the what do you call it now? On the rotator cuff muscles and the acromial process here. We call it Jochum test. Jochum test. Right. Yes. Yes. We now come to the stability test. The first one we want to do is, we call it anterior stability test. Anterior stability test. Somebody that is having dislocation of anterior dislocation of the shoulder, right? This test is very important point. The one should be careful. One, there is history of anterior dislocation. This one should be careful. That the examiner, you have to be careful when there's right? So we call it load and shift test. I think you are following me. So one hand is used to press the shoulder down. Now let's talk about left. Someone is calling. Sorry, please. Hello, what's the problem? That's not it. So you press the shoulder right down. Then the other hand is used to move the head of humerus. You move it forward. You hold it and you move it forward. You shift it. So the left hand is used as the loading hand. Then the shifting hand, right? You expect a kind of movement of that humerus. But if it is too much, you give a grading air. That's going to tell us what and what. So are you people still, are you following me, please?
Yes, we are following you, sir.
Thank you.
Yes.
Thank you.
Following.
Sorry. Yes. So as you move it, right, you may have little movement. And that's why you call it the test is negative. But if you have the movement that's a bit more, that the head of the humerus is fed to be going forward, maybe towards the arc of the head of the humerus, then you can say that we have grade 1. In a case that humeral head rises up over the glenoid rim, but it reduces spontaneously when the cells is removed, you call it grade 2. So you move it and you leave it, and the head comes back, you call it grade 2. But if you move the head of humerus, right, over the glenoid rim and remain dislocated, we call it grade 3. In that way, the load and shift is positive. That means the patient is having, right, all the ligaments of the anterior portion of the glenohumeral joint weak. So you have to be careful so that patient will not have anterior dislocation in the course of your mobilization. So load and shift is positive. That's what it is. Yes, I try to put the grading here. Load and shift test can be used to classify the degree of instability of the shoulder joint. All right, +1, 0 to 1 centimeter, 2 plus 1 to 2 centimeter translation. Right, it may be difficult for you to measure this exactly, but your discretion when you are doing will indicate what. Then 3 plus more than 2 centimeter translation over the glenoid rim. You call it load and shift test. Yes. Aha, good. Good. We have for this one fulcrum test. Fulcrum test of the shoulder joint. Fulcrum test. All right. I think you can see the picture very well. Can you see the picture?
Yes.
So what
Can
you
see
do,
it.
yeah, what you do here is that
Yes.
patient lies supine. Right. He abducts the shoulder to 90 degrees for assembly. The elbow too is flexed to 90 degrees for assembly. Then you try to clench your feet and you put your fist under the scapula. That's what we are seeing here. Then you now try to apply a downward force. Just try to push the elbow down on the clenched feet that you have made. Right? You see, apply a mild anterior directed force using the fist to the posterior head of the head to translate the humeral head anteriorly. So if you have pain on the anterior side, right, it shows that there is a kind of anterior side weakness. Again, if you have much translation, you discover that the head of humerus is coming up is coming up severely, right? That shows that we have anterior instability. We call it fulcrum test of the shoulder joint. Fulcrum test of the shoulder joint. Literature is there for us, at least to be able to enjoy as we are moving down. Yes, outcome. This is positive if the patient feels pain, number one, during anterior transition of the humeral, or apprehensive of having a subluxation or dislocation during the maneuver. Yes, we call it fulcrum test for the shoulder joint. Okay, so if somebody is having weakness of the shoulder joint resulting from hemiplegia, you know that you cannot do it. Cannot do it. There's having dysfunction of the leg. Yeah, we are familiar with it. Call it apprehension test or Clark's test, right? Or crank test. Yes. How do you do that? Patient is standing. As we did for the fulcrum test, but in this case, my patient is standing. So in this way, you just try to do 90-degree abduction, 90-degree flexion, and you do what's called external rotation of the shoulder. Right? You see the patient's face is going to change immediately. No, leave me, because of the pain. Right? And if you discover that the head is coming out, you try to leave it. So examiner then passively externally rotates the patient's arm, looking for resistance, number one, slipping, number two, or obvious signs of apprehension. So you look at the patient. If patient demonstrates or exhibits any of the preceding signs, the test is what is positive for anterior glenohumeral capsule laxity. We call it apprehension test, glenohumeral instability. Right. So I think I'm moving. Yes. Let me try to show you this one very well. They call this one Job or Fowler's sign. Fowler's sign. Call it Job or Fowler's sign. All right. The purpose of Job, we call it Job relocation test. It's also referred to, all right, the test for anterior instability of the glenohumeral joint. It is particularly useful following a positive apprehension test after you have discovered that patient is feeling somehow apprehensive. When you do the apprehension test, we try to do this. We call it relocation test. Relocation test in the sense that it will bring the head of humerus back to the joint. That's why we call it relocation test. Glenohumeral subluxation or relocation test or Fowler test. The patient is lies supine, as I have seen the patient on an examination table. The shoulder is abducted, as you have seen it to the 90 degree, and the elbow is flexed to 90 degree. The therapist applies an external rotation force right to the shoulder. If the patient reports apprehension, then the apprehension test is considered positive. Therapist then applies a posterior directed force to the shoulder joint that if the patient apprehension or pain decreases, the Job relocation test is considered. I think you are seeing the hand of the man. I think you are seeing the hand.
Yes.
Yes.
This is the hand that gives external rotation, right? If we find the patient to be apprehensive, you try now to apply a, what do you call it, posterior force. It's as if you want to do posterior glide. Posterior glide means you hold the head of the humerus and you press it backward. Simple. You press it backward. So when you press it backward, it's expected that that head will relocate. That's why we call it relocation test. So if you're in the sports complex and somebody has anterior dislocation of the shoulder, just try to do Job examination or Job test. It will definitely relocate the shoulder joint. Okay? In the practical sense of it, there may be some distraction. You try to give some pulling, and you press it. So that's going to relocate the joint. So that's why we call it, all right, Job relocation test. Right. Yes. That one speaks for the anterior test. We now have what we call posterior Okay, we call this one anterior drag test, please. Anterior drag test. Right? You know, in the knee joint with that manual therapy, we have anterior drag test. We have posterior drag test. So at the shoulder as well, we have anterior drag test. We have posterior drag test. We may not be familiar with this, but it's happening. It's happening. So there can be anterior drag test for the shoulder joint to diagnose injury or damage to the shoulder joint, maybe to assess the instability. You know, the anterior drag test for the knee assess the cruciate ligament, anterior cruciate, and posterior assesses posterior cruciate. Then when you come to the elbow joint, you don't have cruciate joint, cruciate ligament. Then we have the anterior ligament, we have the posterior ligament that holds the joint together to make it stable. So the anterior drag test, we assess the anterior ligament. It can also be used on arching shoulder, where the application test is difficult to interpret. And it has allowed us to reliably diagnose anterior subluxation, even in patients who may have a negative application test. Right? If there's a mild subluxation of the shoulder joint, especially anteriorly, and you do the apprehension test, patient doesn't give any sign. That's what we are saying here. Then one may go and do what's called anterior drag test. The question is that, how do you do anterior drag test? Then you are following me? Yes. Can we see this? I think you can say the,
Yes.
you can see the picture.
Yes.
So what do you do here? Patient lies supine, right? Then after then, the patient relaxes the affected shoulder by holding patient's arm. You hold patient arm, you hold the shoulder then. Then abduct the patient's shoulder between 80 and 120 degrees. Between 80 and 120 degrees. You try to abduct it. Then forward flex up to 20. So you flex it, right, certain extent, 20 degrees. Then laterally rotate up to 30 degrees, right? Then step 4, stabilize the patient's scapula with the therapist's opposite hand. That's what you are seeing here, right? This one is trying to maneuvering the hand. This one is trying to stabilize the scapula. Then draw the humerus forward. You just try to pull the hand forward. But please, you have to pull it gently. So you are not going to remove the shoulder. Of course, you can't remove it anyway. If there's a dislocation there, then it may really be. So you may have to pull it gently. So when you pull it gently, then that's an observation. Positive tests indicate the anterior stability. So you are trying to see that the movement is small. Draw the humerus forward anteriorly using the hand that is holding the patient's arm. Positive tests indicate the anterior stability decided by the amount of anterior translocation you observe. So how much were you able to pull it? Right, we call it anterior drag test. So if you're able to pull it more, that shows that there's laxity of the anterior ligament and the patient can have anterior dislocation. So we call it anterior drag test. Right. Yes, and this is the grading of the movement. You have grade 0, minimal displacement. You have grade 1, humeral head reaches glenoid rim. So when you pull it, you are going to feel it. Then grade 2, humeral head can be dislocated or spontaneously released. Don't forget that we did load and shift the other time, and we have grading. So the same grading is what we are trying to put down here. And grade 3 is humeral head does not spontaneously reduce. So that shows that there is serious instability of the anterior ligament. So that's why you are careful on what to do for the patient. Majorly, you strengthen the joint of the ligament of the patient. Then we have posterior instability test. Load and shift goes for that as well. All right. When you see that load and shift, you can move it anteriorly. You can move it posteriorly. The posterior movement is what we call posterior shift. Do you understand? Cannot anterior shift. So posterior shift tests for posterior instability. Anterior shift tests for anterior instability. Then we have posterior apprehension test. We have posterior thrust test. We have jack test. So all those ones were for posterior instability. Yes. This is great. Good. And this posterior apprehension test, patient just sit down, flexes the elbow to 90 degrees, shoulder to 90 degrees. You apply a force anteriorly. Just apply a force as if you are doing a compression test when patient is lying down. So when you do that, right, you look for pain. Then you look for apprehension. You call it posterior apprehension test. So that's the demonstration. All right. So when there's apprehension, that means that the posterior ligaments are weak or patient can have posterior dislocation. Call it posterior apprehension test. Yeah. This is posterior thrust test. You know, the other time we talked about anterior thrust test. Now we are talking about posterior thrust test. So in this case now, patient just lying, right, supine, right? The elbow is flexed as we are seeing it. The shoulder is slightly flexed and abducted as we are seeing it. The examiner holds the head of humerus. So you hold that head. You hold that head. So when you hold that head, then you apply a force, try to give a pulling down posteriorly. The other one, you pull it up. You pull it up here. But now you try to pull it down now. So when you pull it down, then if there are displacements, as you are feeling it, we say that the posterior ligament is weak. The posterior displacement can be appreciated as the thumb slides along the lateral aspect of the coracoid process. You understand? Towards the glenoid, and the humeral head against the ring finger, against the ring finger of the examiner's right hand. This maneuver may be painful, but often associated with a slight moderate degree of apprehension. So if you now observe that the movement is severe there, that shows that the posterior thrust test is what is positive. We'll have more to that here. All right. Then here we have what we call jack test. Jack test. The test is a physical examination help to diagnose shoulder instability. It involves applying a sudden force, right? Sudden force to the shoulder while the patient arm is abducted and internally rotated. Do you understand? Right? It's abducted and internally rotated. Ask the patient to sit or stand with the arm on their side. Grab the patient forearm with one hand and the upper arm with the other hand. Then passively abduct the patient arm to 90 degrees and externally rotate it. Right? There'll be apprehension. Apply a sudden and forceful posterior direct force. So you apply the forceful. You apply posterior force as if you are doing posterior apprehension. Then this case is going to be sudden. Just apply it all of a sudden. When you apply all of a sudden, you look at the patient expression. Right? It may give you a kind of expression there that will make people know that this patient is having posterior it can have posterior subluxation. If a sudden jerk or trunk sensation is felt during the jerk, it means it suggests posterior inferior instability of the glenoid joint. Right. Yes, having tested for the posterior instability, they have to test for inferior instability test as well. And this is the what's called sulcus test. Sulcus test. Sulcus test. It gives a kind of inferior stability of the shoulder joint. The sulcus and test that check for shoulder instability. This is to evaluate the glenoid humeral joint. Have the patient sit or stand with their arm relaxed at their side. Hold the forearm, pull it down. I want to advise that you do this one with a sense of caution so that you are not going to dislocate the shoulder more. Once you observe the sulcus here, just apply a mild force. Right? We try to promote what you have there. and that will give it a kind of positive indication. A sulcus indicates that the shoulder is pulling away from the socket. It's a sign of multidirectional instability, right? And it indicates inferior stability of the joint. A positive result is indicated by a significant downward displacement, which you have to be careful about, or else you will not be able to return the joint back to where it is before. Right. Then we call this one labral test. You know, in the joint, you have the capsule, and you have the cartilage that encloses the joint, that gives it a kind of concavity where patient, right, where you can have the head of the humerus that moves. So if there's a kind of tear of that cartilage, we say we have labral tear, and can be at the inferior side of the joint. All right. So in that way, we call it arm forward flexion test, or labral, what do you call it, test. The patient abducts the arm to 10 degrees to 15 degrees. Then you thumb down. So when you thumb down, then the PT apply a pressure. Look at it. You apply a pressure. Right? When you apply pressure there, patient may feel pain. Patient may feel pain at the glenohumeral joint here. Right? And you repeat it 2 or 3 times. So when the pain is still there, then shows that, oh, there's possibility of that structure to have been torn. Right? So just labral tear. And you know, with that now, you have been able to diagnose posterior ligament, you have been able to diagnose anterior ligament, you have been able to diagnose labral tear, you have been able to diagnose impingement. All those ones are at the shoulder joint. At the shoulder joint. So then we have this one, anterior slide test. Anterior slide test, yes. The anterior slide test examine helps to determine if there's a labral tear as well. Patients sit with their hands on the hips. Look at it. The hand on the hip. The examiner stabilizes the shoulder. Look at it. And the scapula. So you use one hand to hold the shoulder. The palm of the hand is holding the scapula, pressing the scapula. So you are touching the scapula, you are holding it. Right? Then the examiner uses the other hand to push forward and slightly upward the elbow. So look at it now. You now try to use this hand to push the elbow forward. Just push it forward. So as if you want to grind the head of humerus against the arch of the acromion clavicular joint. So then what happens? The patient receives the push. When patient receives the push, a positive result is indicated by pain in front of the shoulder, a pumping or clicking sound in front of the shoulder, right? Symptoms that occur during overhead activities. So all those ones will indicate that there's labral tear, especially at the upper part of the shoulder. The other one is talking, oh yeah, the two are talking of the upper part of the shoulder then, right? Then there's compression rotation test. Compression rotation test is a shoulder test that can help identify shoulder pain and instability as well. It can detect labral tear as well and acromion lesion. So patient lies on the back with their shoulder abducted 90 degrees and their elbow flexed 90 degrees. The examiner applies pressure to the patient's upper arm. They apply pressure to the patient's upper arm at the elbow. The examiner rotates the patient's shoulder internally, rotate it internally and externally. Bring it in, you bring it out. Right, the patient receives the examiner's pressure. Right, tell the patient to resist it. So when it resists it, then the patient pain in the front of shoulder may indicate a kind of compression. A click or pump. So all those ones were indication for the cartilage inside the glenoid fossa. If they have problem, you call it labral tear. Yes, there can be scapular instability. We call it scapular instability test. So, you know, we have talked about the glenohumeral joint majorly. There can be scapular instability as well. There can be, what do you call it now, clavicular instability. That's what you do by palpation. and movement. The scapular instability tests include the scapular assistance test, we call it SAT, the scapular distraction test, and the scapular dyskinesis test. These tests help assess the function of the shoulder blades and diagnose scapular dyskinesis. I've shown you pictures the other time that shows different kind of dyskinesis that you have. That when you have the bulging of the anterior portion, the upper part, the middle, the lateral border, and lower part of the scapula. All those ones are what you have there. How do you test them? Evaluate the scapular assistance test, SAT. Evaluate how scapular movement affects shoulder pain and function. A positive test indicates weakness of the scapular stabilizers, right? That's subscapularis, anterior anterior, and the supraspinatus and infraspinatus. The test is considered positive if the pain decreases with assisted scapular movement, right? How do you do that? Are you following me?
Yes.
Good.
Yes, sir.
I think you can see this picture.
Yes.
Good. We have been talking about pain all the while. Then this test now, this maneuver will reduce the pain. The test can be performed when patient is seated or standing to allow the free arm movement. Right? What's your own position? Clinician position. The clinician stand behind the patient. You stand behind the patient to manually control scapular motion. You try to hold the scapular motion. You try to hold the scapula. You prevent it from movement. Right? The test can be performed with patient. I think I've mentioned that. Right? So you now tell the patient to move the shoulder, move the hand forward. So when you move the hand, you try to hold the scapula so that you try to assist it in the movement. Then positive SAT, a reduction in pain or an improvement in range of motion during the assisted movement suggests that there's problem with movement of scapula. They suggest that you have scapular dyskinesia because it's a significant contributor to the movement of the shoulder. Right? I try to report it here. Negative SAT. No noticeable improvement in symptom or motion with scapular assistance. That shows that the patient does not have scapular dyskinesia. And when it is positive, when there's reduction problem, it means that the patient is having scapular dyskinesia, and one can go and treat it. We call it scapular assisted test. Then we have scapular restriction test. The scapular restriction test stabilizes the scapula in the retracted and grades the strength of the supraspinatus muscles. The neutral retracted position improves the strength of the supraspinatus, allow it to produce maximum force. I think I have the picture here as well. Yes, I have the picture here. In this way, the patient flexes the shoulder to 90 degrees, internally rotates it, right, and hold it in the caption position. So you try to use the hand to hold the trapezius so that the scapula will not try to move. That's what we call scapular retraction, right? The patient's shoulder is internally rotated close to 90 degrees and head in scapular position. The examiner applies a downward directed force. You apply downward directed force to the arm, number one, and the patient tries to resist it. So as you apply, patient tries to resist it. The test is repeated with the examiner stabilizing the scapula. So you do it first. When patient resists it, after then you try to prevent the scapula from moving, right, in a retracted position. The examiner fingers cups the patient's anterior shoulder firmly over the clavicle. This is the hand. So you hold it, you hold the scapula. No, the clavicle, you hold it firmly. You try to press it, right? So with his forward resting on the medial border of the patient's scapula. The test is positive if the strength of the rotator cuff is restored, indicated by being able to resist the examiner's downward force. So your patient will be able to push you more because you have restricted the scapula. So in that part, it's showing that the physical cuff muscle is the one that's having a kind of problem, right? So we call it the scapular retraction test. Yes. This is another one. I think we have seen this. Are we seeing this?
Yes,
We're about
Prof.
Yes.
We call it this. We call this one scapular. This kinesis test. Look at the scapular air. The start, right? Elevated as far as possible. Tell the patient to elevate it, right? During the test, then they return it. What is the state of the scapula when all these ones were done? We call it scapular dyskinesis test. And don't forget, I've shown you what this kinesis test is the other time, that there can be protrusion of the scapula. You look at this one, it looks normal. Then when you get there, it seems as if there's a kind of protrusion here. Look at it posteriorly. That shows that possibly the scapula is having a problem. Either serratus anterior or subscapularis is having a problem. The patient actively flexes and abducts the shoulder while a clinician observes. The patient assesses the scapulohumeral reading. You look at how this scapula moves, how it moves. You look at it. The patient repeats the motion 3 to 5 times. The clinician may ask the patient to repeat the test with weight, right, in each hand or without weight. The clinician rates each movement as normal, softly dyskinetic, or obviously dyskinetic. So you look at how that movement is. If the movement is reading good, if we discover that one scapula is not moving as it's supposed to move, that may be mild. If we discover that the scapula is not moving at all or is bulging out, that's obvious. That's obvious dyskinetic movement. So we call it dyskinesia movement. Yeah. Then we call this one the scapular sliding test. Very interesting. Scapular sliding test. I think you are following me. Yes, very interesting. What you do here is that you measure from the angle in a lateral angle of the scapula to the spine. You measure it. It has a range. I put it here for us. It has a range. While patient is resting, while patient put the hand to the back, and while patient lift the hand up, maybe abduct to about 90 degrees, you measure it, right? We call it lateral scapular slide test, assessing the scapular asymmetric, both sides, and ability of the scapular stabilizer muscles, right? To make the scapula to be in the position. We call it scapular slide test. Just measure the amount of scapular rotation protraction in 3 positions, right? Shoulder joint abduction by measuring the distance from the midline to the medial body of the scapula. The test may be used as a quantitative measure, yes, of scapular stabilizers muscle strength during the rehabilitation program. The test in 3 positions. 1, with the arm abducted to 0 degree, to 45 degree, and to 90 degree in coronal plane. Position 1 involving placing the shoulder in neutral position. That's what we are seeing here. That's position 1. With the arm relaxed on the side. Position 2, the humerus is placed on medial rotation. Right? You tell the patient to do medial rotation and 45 degree abduction by positioning the patient hands around the waist. That's what we are seeing here. Then position 3, the humerus is placed in the maximal medial rotation, right, at 90 degree of abduction. The test is positive, right? The test is positive. Right, let's go down a bit. Yes. When there's difference of 1.5 centimeter when you measure them. You measure the first one, you measure the second one, you measure the third one, and subtract them from each other, right? When the difference is more than 1.5 to say that the measure the test is positive. All right. Yeah. There's muscle and tendon pathology as well. Right. I think we have only a few slides more to cover that. Right. We have tendonitis, we have tendinosis, we have rotator cuff tears, we have frozen shoulder. For tendonitis, that's inflammation of rotator cuff or biceps tendon. It can be caused by tendon being pinched by nearby structures, can occur in sports and required repetitive overhead arm motion. Tendinosis, yes, this is tiny tear. Yeah. Tendonitis is inflammation. Tendinosis is tiny tear. And that can result from the rotator cuff or biceps tendon. There can be rotator cuff tears as well. There can be frozen shoulder. So all those ones were right, some of the muscle problems that we may have. All right. You have this, we have biceps tendon. We call it speed test. Speed test. Speed test. How do you do that? You tell the patient to, right, elbow is flexed to 20 degrees to 30 degrees, arm is abducted to 60 degrees. Then you tell the patient then to flex the arm and you resist it. And you resist it. You resist the end against your hand. You call it speed test. But it examines the bicep tendon or weakness. Call it speed test. All right. Then we call this one Yergason test. Yes, Yergason test. The Yergason test was designed to assess the pathology of the long head of bicep in its shape. The patient elbow is flexed, right, to 90 degrees, and the arm pronated. The examiner holds the arm at the wrist, right? Patient actively supinates. So tell the patient to supinate the arm against your force. Call it Yergason test, against your force. So if he does that and there's pain at the bicep where the examiner is touching air, the Yergason test is positive. We call it Yergason test. Right. Yeah, this is drop arm test. Drop arm test, very interesting. Drop arm test. What happens is that just tell the patient to abduct to his side and tell him to drop to leave the hand. So when he leaves the hand freely, the hand shouldn't slap on the patient's body. But if the hand slaps on the patient's body, it shows that the supraspinatus is affected. So that's what we are saying. I call it drop arm test. Drop arm test. It's a test for rotator cuff dysfunction. Call it drop arm test. Right. Yes, we are familiar with this as well. We call this one empty can test. What does it mean? You tell the patient to kindly do as if you want to throw away something from the can. Tell him to throw away something. So when he does that, that patient just try to resist the movement in lifting it up. You call it drum arm test. So patient will feel pain at the supraspinatus region and the shoulder joint. So that drop arm test is positive. Place the arm horizontally to 30 degrees, internally rotate the shoulder fully, apply resistance. It's going to be positive or pain. If the patient is positive, if the patient is having a problem there. Can call it as Job test as well, but not as the other one. Okay, maybe it looks like the same. All right. Then this is the last one that we are talking about. We call it thoracic outlet syndrome. Thoracic outlet syndrome. There's a test we call it the Rules test, wrist test, then costoclavicular syndrome test. So in this case now, the thoracic nerve is impaired. There's a dysfunction there. You want to test them. We call it the Rules test. So what do you do when it comes to Rules test? All right. You just tell the patient to lift up the two upper limbs. Look at it now. Patient abduct the shoulder to 90 degrees. The arm, the elbow is flexed to 90 degrees. And he just lift it there like that for some period of time. Maybe 10 seconds or thereabout. Then there will be pain. There will be pain from the hand, possibly back to the shoulder joint. You call it Rules test. Right? The test is diagnosed used to identify thoracic outlet syndrome. It's also known as elevated arm stress test. east. Starting position, patient has both arms in 90-degree abduction, external rotation position. Shoulder and elbow are in front plane of the chest. The patient is open and close the hand slowly over a 3-minute period of time. So close the hand slowly over a 3-minute period. Result, if normal, only for arm muscle fatigue and minimal distress. But at times, the pain may go from the hand to the shoulder joint. We say pulse is positive. Then possible symptoms present gradual increase in pain at the neck and shoulder, progressing down the arm, paresthesia. In case of arterial compression, arm pallor, yes, patient is going to feel that the palm is no more, there's no circulation there. They activate hyperemia when lip is lower. In case of venous compression, cyanosis and swelling may occur. Inability to complete the test for 3 minutes. The patient drops the arm immediately. So all those ones were signs that we have thoracic outlet syndrome. Right. Then we call this one wrist test. We are getting towards the end of the show. We call it wrist test. All right. Procedure. The test is performed in 2 steps. First step, right, head forward, while the arm is passively brought into abduction and external rotation to 90 degrees. The elbow is flexed no more than 45 degrees. Right? You can see it. The arm is then held for 1 minute. Just hold that arm up. The tester measure radial pulse. So you put your index finger at the radial pulse here and you measure it. Right. The tester monitor the patient's symptoms onset and quantify, right? Yes, and quantify of the radial pulse. You try to hold that radial pulse. Is the radial pulse still there or is fainting? If the radial pulse is fainting, that means this test is positive. That shows that, right, the blood supply there is a bit weak, right? Indication of problem with the thoracic outlet. That is repeated with extremities in hyperabduction, end range of the abduction, right? Positive test, a decrease in radial pulse or production of the patient's symptoms is an indication for thoracic outlet. This is going to be according to the last one. Postclavicular syndrome. Yes, patient is standing, the examiner palpates the radial pulse, right? And they now try to take the hand to the back. So when you take the hand to the back, you palpate the pulse again. A positive test indicated by an abscess or decrease in figure of the pulse and implies possible postclavicular syndrome. Maybe at the postal region, at the clavicular postal region, there's a problem there, and the vessel there is being impeached. Call it postclavicular syndrome. It is also positive if the client experiences an increase in neurological symptoms into the upper extremity on that side. That's particularly effective in patients who complain of symptoms while wearing a backpack. They have been wearing the backpack, maybe it has really affected the structure there. All right. Shoulder arthritis, yes, I think this is going to be the last one. Of all what we have been discussing, we discovered that we did not really mention osteoarthritis of the shoulder. But that's very important. So good common that happen. So in that case, right, you have to examine the humeral joint. There can be stiffness of the joint. There can be grinding when you move it passively. There can be cracking when you move it passively. So all those ones were signs, right, and possible symptoms that patient may have with the what do you call it, humeral joint arthritis. Then one can do a kind of compression test, right? You just tell the patient to lie supine. You try to compress the shoulder joint. By and large, to confirm that, one may need the X-ray of the joint. And when you have the X-ray of the joint, it will show you the status of the head of, right, humerus. and the glenoid fossa. And what you are seeing here, can see degeneration here. You can see abnormalities at the edge of the humerus. Look at the glenoid cavity here, can see that it's eroded away. So those are the signs of osteoarthritis. You can imagine that, okay, in other dysfunction, X-ray will not show this. X-ray will not show this. All right. Conclusion. Thank you very much. The test will not be exhaustive. There are other tests. But with this one day to come to the diagnosis that this is what the patient is having. And once you are able to make the right diagnosis, the intervention is very, very easy and productive. I want to say thank you to everyone. God bless you. Don't mind us. We take too long today. This is about 6:30. We have started from 5. Okay, that's one and a half hours. It's not too bad. Thank you very much. God bless you.
Thank you. Thank you, sir.
Thank you, sir.
Thank you, Prof.
Thank you so much. At this juncture, I would call on PT Marlin to moderate the question and answer session. PT, if you're on board, please take over.
All right. Thank you very much for the opportunity. Professor, thank you so much for that very informative presentation. And this webinar cannot. Hello, please, thank you.
Yes, you are loud and clear.
All right. So this webinar cannot come to a perfect completion without us having a Q&A session. So if any of us has a question, you can kindly unmute and then ask Professor. He is ever ready to answer. Alternatively, you could always send your question to the chat box and I can read it out to Professor for you. So the floor is now open for questions.
Okay, thank you. Hello, Prof.
Yes, sir.
During the initial part of your submission, you made mention of the sulcal sign being visible anteriorly. I want to understand between anteriorly and laterally, which one do you think, in your opinion, would the sulcal sign be more visible between anteriorly and laterally?
It's more of lateral than anterior.
Okay, thank you so much.
Anything on the lateral side, but it's more of lateral than anterior. Thank you very much for that observation.
I'm grateful, Prof.
Yeah.
Please, any other questions?
Thank you for the presentation, Prof.
Thank you.
Please, can you please probably explain the different categories of scapular dyskinesia as explained in the presentation? Because most of the times we just talk of Wenger scapula.
Thank you. We discussed this extensively last Saturday.
Okay.
Last Saturday, right? Maybe after now, right? We may. Okay. Let's go back to the slide. Let's go back to the slide and see.
Thank you.
You may my moderator, please kindly let me have the slide. I think we have this slide. Can't start. Let me share what I do. So kindly let me to give me the platform. Thank you. Yes. Right. Aha. So we talk about dyskinesia. Right. There are right. I think we are going there gradually. Yes. So when you have issues with the muscles that surrounds the scapula, then you can have dyskinesia. And dyskinesia means possibly there's problem with the nerve that supplies the joint. Maybe there is problem with the muscle, right? I want to see where I put it down for you. Okay, no, there's another one up there where we are doing the observation. All right, yes, where we are doing the observation. So, and that determines how the shoulder will be protruded. It will be protruded. So that protrusion covers what we call wing scapula. And wing scapula is in category. You understand? So there can be, there can be, just 1 minute, please. This is hanging up. Right. So when there is problem or weakness of the subscapularis,
okay,
the scapula will wing up. Right. When there's problem with the serratus anterior, the scapula will wing up. So, and you measure that, or you see that when you expose the back of the patient, you're able to see that, right? Yes, this one of them. All those ones are you seeing? Can you see my slide?
No, Prof.
Yeah, not sure.
No, sir. No, sir.
You are not sharing.
I'm not sharing.
No.
Is the thing up? Sharing? Aha. Yeah.
Okay. Okay, now we have it.
Okay. In this case now, right, you may have the trapezius affected, you have the subscapularis affected, you have the serratus anterior affected. So patient is unable to lift up the shoulder. So it's wing scapula as well. That's what we know. Don't understand. But what we are saying that scapular dyskinesia is more than that. It's more than wing scapula because all those structures were affected. And from the discussion last week, if you have all those muscles weak, possibly paralyzed, you can only strengthen them. You cannot mobilize the scapulothoracic region, or else you just remove the scapula from the thorax because it's not a very strong joint. It's a pseudo joint that doesn't have attachment. The only what you have there is the muscle, and the scapula itself is attached to the is anchored up by sternoclavicular joint anteriorly. And that's the only joint that joins the scapula to the other part of the body. Okay, that is it. Then you now have another one, possibly at the acromioclavicular joint. So those are the joints that join the scapula to the body. So in that way, find it difficult to mobilize them, but you can strengthen the trapezius. You can have a means of strengthening the serratus anterior, and that's by virtue of your exercise. So all those ones who are part of scapular dyskinesia are majorly, right? We have it here. Do you understand? So you can have the anterior edge or the lower border of the scapula being bulged. This one. You can have the lateral border or medial border being bulged. And you can have the upper border being bulged. So all those ones were various categories of spinal dyskinesia. I will take the permission from my people in Ghana to send the slide to you so I'll be able to have reading of it and possibly get better understanding to save our time. Thank you.
Thank you.
Yeah.
Thank you, Professor. Do we have any more questions? All right. If there are no questions, if there are any volunteers who would want to share with us what they learned in today's session, we'll be happy to receive that. Just 2 people who are willing to share with us what they learned from this very informative webinar.
Hello. Today I learned that if the long thoracic nerve is injured or have a problem, it could affect the trapezius, which will lead to uneven symmetry when you try to draw the line posteriorly at the back to check the level of the scapula. I don't know if that is the right information, Prof.
Yes, you are right. You are very right.
Okay.
You see the sagging of the scapula down. Patient will not be able to do scapular retraction, not be able to retract your scapula up or lift the scapula up because the muscle that's going to lift it up is paralyzed. Then that was when we need to be strengthened that. So, and that's what we discussed again last week.
All right, one more person and then we'll be through with this session.
So in the next 2 weeks, we'll be discussing on the management. Once we know what the problem is, the next thing is management. So, and that is going to teach us more on possibly mobilization technique and some other technique that we can use to resolve the problem once the problem has been detected. So I want to appreciate my people from, let me say, diaspora. So Ibrahim Boehm, I have to appreciate you. Michael, I want to appreciate you. So and there's a lady talking on that gun. So I don't know, I don't have your name here. I have to appreciate you as well. So it has been a good collaboration between Nigeria and you people there. You are wonderful. All right. How about our friend from India?
We hope to.
Is he on the platform?
Prof, yes, I'm here. I'm at the back end.
Oh, that's great. That's
Right.
great. That's good.
Okay. So I think Ibrahim and PT Jenfi will conclude for us, and then we end today's section.
Sure, Michael. Prof, what more can we say? Thank you so much. It's always refreshing to have fine brains like you to share with us your ocean of wisdom. And we thank all of you that took time out of your busy schedule to join this meeting. We really, really, really appreciate your time of joining the meeting. I would also encourage all of us to try as much as possible to subscribe to the channel Physio Instructors so that they can motivate us to keep on doing the good works. As Prof said, exactly 2 weeks from today, we hope to commence the 3rd session of this webinar, which will focus on mobilization techniques for the shoulder complex. And we will be focusing on techniques such as gliding, distraction, soft tissue manipulation, muscle energy techniques, and special focus will be placed on the scapulothoracic joint. So we hope to see you 2 weeks from now. Until then, Michael, do you have further submission?
Thank you very much. I want to say
thank you so much.
Council in this nation approved this work. All right. It's approved by Medical Rehabilitation Therapy Board of Nigeria, and we have the CPD for it. For whoever that is interested, the certificate will be given at the end of the 3rd module, that's the next 2 weeks. Again, I want to appreciate the people that have come together to bring this one up. God will be with you. God will strengthen you. Okay, so we move forward around the world. Thank you.
Thank you, Prof. Until we meet ourselves again.
We appreciate your time and efforts.
Okay.
Okay. All right. Have a nice evening to everyone.
Same to you.
Thank you.
God bless you.
Bye.
All of you will come to Gwagwalada FCT for our workshop, right?
Sure, Prof.
Now, I want to see
I hope to meet you in person one day.
Please come there. And I want to see Michael as well. So, and
all right, Prof.
I want to see all of you there at Gwagwalada. Please come.
Sure,
You will
Prof.
enjoy it. God bless you.
Okay.
Thank you. Yeah.